portfolio, he also served in a number of government positions, including as the Minister of the Department of Health during the SARS epidemic. And I actually visited Taiwan shortly after the SARS epidemic, and walking down the street with Dr. Chen, we would see people going, you know who that is? You know who that is? Because I guess he had been on television so much during the epidemic. He was also a minister of the National Science Council. More amazing to me is that an epidemiologist was elected as the 14th vice president of Taiwan. We should be so lucky in this country. Most recently, he served as the premier of Taiwan, stepping down this past May. Dr. Chen has dedicated himself to molecular and genomic epidemiological research on chronic arsenic poisoning and virus-induced cancer, primarily hepatocellular liver cancer. His groundbreaking research on the health hazards of arsenic in drinking water have led to global awareness and efforts at mitigation, and his research on chronic hepatitis B virus has pioneered the viral load paradigm in its clinical management. He has published over 800 papers, and he's still going strong. He received many honors in Taiwan, too many that I'm not going to mention, but I'm also going to mention some of the international ones, including that he's a member of the U.S. National Academy of Sciences and the Pontifical Academy of Sciences at the Vatican. He was the Cutter Lectureship on Preventive Medicine at Harvard and Knowledge of the World Award at Hopkins, the Order of the Academic Palms from France, and two that I never heard of, a Knight of the Equestrian Order of the Holy Sepulchre and the Pontifical Equestrian Order of St. Gregory the Great in the Vatican. More importantly, he has been a wonderful collaborator to several of us. He was an advisor on Joe Graziano's Superfund grant studying arsenic exposure in Bangladesh for many years. And for 24 years, I had a grant to study liver cancer that started with my first graduate student introducing me to CJ. He obtained a Fogarty Fellowship and has spent a year working with us on analyzing DNA damage in liver tissue resulting from exposure to aflatoxin, a liver carcinogen. This was followed by a long line of outstanding students and postdocs who came to my lab, including Dr. Chen Wu, who is currently an assistant professor in the department, and several others who are in the audience. None of this information conveys what is so wonderful about CJ. Despite all of these accomplishments, I hadn't quite realized how many until I read his CV. He is a really nice person. I was trying to think of a nicer way to say that, but a really, really wonderful person and a wonderful collaborator. So it's all yours, CJ.
Thank you very much, Regina, for your very kind introduction. It is really my pleasure and honor to give this special seminar in honor of Professor Regina Santella. And today I'm going to talk about this, molecular epidemiology and public health policy, precision transition from scientific discoveries to betterment of human well-being. And my research institute is on the multiple health hazards of long-term exposure to arsenic in drinking water. And we call this the BFD study. It's a black foot disease. And we engaged in the environmental risk assessment and also precision toxicology. We try to elaborate genetic and acquired susceptibility to arsenic poisoning. And the second part of my research institute, interest is the natural history and liver cancer risk prediction of chronic hepatitis B and C. I'm going to talk more about this because it has been implemented into our public health policy in Taiwan. And we call this a review HBV HCV study. And we have engaged in this precision risk prediction. And we also set up the viral load paradigm for clinical management of viral hepatitis. And we also evaluated the effectiveness of HBV vaccination and antiviral therapy of chronic hepatitis B and C in Taiwan. And now we have a determination to eliminate viral hepatitis in Taiwan 5 years before WHO set up the goal 2030. And the third part of our research is on molecular and genomic biomarker of biological agent-related cancer and look at this gene environmental interaction. We look at the nasopharyngeal carcinoma. This is a very important so-called Chinese cancer because Chinese ethnic group has a very high instance of NPC. And we look at this Epstein-Barr virus seromarkers for screening, diagnosis, and prognosis. And we also look at this Helicobacter pylori and stomach cancer and cervical cancer and multiple type of human papillomavirus. Excuse me, maybe I use this one. Okay, I would like to thank Regina for giving me a chance to engage in molecular epidemiological research. Dating back to 1990, molecular epidemiology is still at its very early stage. It's a so-called infantile stage. And I came here to learn a lot from her group. And he just mentioned about the Fogarty International Research Fellowship from the NIH. And in her group, I'm very lucky to collaborate with Dr. Zhang Yijun as well as Dr. Ms. Wang Nianwen. And we have many postdoctoral fellows trained by Dr. Santella, including Lin Huiyu, Huang Liyu, as well as Chen Shuyuan. And just now, she mentioned about this Lin Xie. I would like to give special thanks to Lin. She passed away already at a very young age. It's a great loss to the epidemiological society in Taiwan. And Lin once went back to Taiwan and said that she's studying molecular epidemiology with Dr. Santella. At that time, I have no idea about what is molecular epidemiology. And thanks to her, I have the chance to know what is molecular epidemiology. And thanks be to God for giving me the chance to come in here. And then we can work together with Regina and her group. We co-authored 45 journal articles and 2 book chapters. It is really a very enjoyable and very successful, and to me, it's very important international collaborative study. It's not only from academic point of view, it also from very good interpersonal relationship. I learned how to be a very outstanding, respectable environmental health scientist, such as Regina Santella. This is once I have a friend give me some information. There's a website called research.com, and then they try to using an index, so-called D index and matrix. And this is the data in 2022. Fortunately, I was ranked as this #1 medicine scientist in Taiwan and the third and the best scientist in Taiwan in 2022. But more importantly, as you can see here, I would like to point out that there's a so-called frequent proposal, and the #1 is and just mentioned about this public servant. I myself like academic research very much. It is mainstream of my lifelong career. But sometimes there's a calling for me to come out to serve my people in Taiwan. And I always consider as to be the minister or to be the vice president or the premier. Basically, to me, it's a kind of a public servant. Just as Pope Francis once said that the true power is services. So when I became this minister, I always consider myself as a public servant. And I try myself to use this scientific knowledge, evidence-based information to provide good public services to people in Taiwan. And now I would like to share with you some examples how we use this academic scientific discovery to this public health policy decision. I just mentioned about this instance of nasopharyngeal carcinoma in Chinese population. And as you can see on this map, Chinese in southern China, as well as those in Southeast Asia, have very high instance of nasopharyngeal carcinoma. And in our collaboration with Ellen Hirdeshan of our National Cancer Institute, we found that EBV virus marker is very important. For those who were positive for anti-EBV BCA IgA markers, have a relative risk around 60-fold compared with a negative one. And we look at this anti-EBV DNase antibody, and we found that the higher the anti-EBV DNase, the higher risk of nasopharyngeal carcinoma. But this is a kind of cross-sectional study. If we want to use biomarkers to do any kind of application, we have to know that whether the cancer comes first and then the high titer, or there's a high titer comes first and then the development of the NPC. So for us as an epidemiologist, I think most important thing is that we have to set up a long-term follow-up cohort and then collect the biospecimen at the very beginning. And then after you collect the information and you follow the patient until they develop the diseases, and you can check the biomarker before the development of the disease indeed is elevated or not. And this is the study we carry out in Taiwan. And the data was published in New England Journal of Medicine in year 2001. And as you can see here, if we look at this IgA antibody, anti-EBV BCA IgA, we found that indeed there's an increased risk of nasopharyngeal carcinoma. Positive versus negative is around 25-fold. And for anti-EBV DNase antibody, is around 4-fold. If both markers are positive, then the risk is really significantly increased. And this slide shows that we have 16 years follow-up. And you can see for those, the upper curve is for anti-EBV BCA IgA positive or anti-EBV DNase positive or both. And for seronegative one is much lower. But I would like to let you know that for those who develop the NPC much later, after 7 years and afterward, when you have a serial collection of biospecimen, and you will find that there's the biospecimen collected before 1 to 5 years ahead of the development of the NPC, their antibody titer already elevated. So it's very important for us when we want to do very good molecular epidemiological study. You have to have a long-term follow-up study, and you have to collect serial samples, and then you can see the natural examine the natural history of the diseases. And I just mentioned that if this biospecimen were collected 1 to 5 years after the enrollment, you can see the relative risk can be as high as 85-fold for both positive person. But if this are greater than 5 years after enrollment, then the relative risk is much reduced. And this means that EBV markers is a so-called short-term markers. It means that once it's elevated, then the disease will come out quite immediately. So it's so-called that's a late-term biomarkers. And we also use these kind of markers, try to apply it to public health practice. And fortunately, we have the chance to collaborate with the Zhongshan Daxue in Guangzhou and in China, and also with Hong Kong University. And then we found that this EBV antibody indeed is very effective for the detection of NPC with sensitivity for the early stage is 87% and late stage is 89% sensitivity, and specificity is 94.9%. But as an epidemiologist, you have to try your best to apply the most updated biomarkers for all kinds of analysis. And fortunately, we have already have the blood sample stored at the very at the deep freezers, so we can retrieve these samples and to test the EBV DNA and using the RT-PCR as well as next generation sequencing. And we found that, oh my God, there's an DNA algorithm is better than antibody score. And this is a kind of, so I don't have time to go through the detail, but this is an AURC curve. The area under the curve is 97.1%. It means that EBV antibody score is a very good predictor for this MPC, but EBV DNA algorithm is even better. And then we come up, we come up a clinical guideline for this early detection of nasopharyngeal carcinoma in high and intermediate risk region. And the paper just published in Journal of Clinical Oncology. However, we found that even we know that EB virus and antibody marker is very important and the DNA marker is important, but there are other environmental factors such as nitrosamine intake during the weaning, long-term cigarette smoking, or dust exposure, formaldehyde exposure, and they are associated with increased risk of MPC. But the green tea and coffee consumption and fresh fish intake is associated with lower risk of MPC. And on the right-hand side, and you can see that in addition to the EBV markers, family history is very important, and several genotypes such as CYP2E1 and DNA repair enzyme XRCC1, HOGG1, they are all associated with this MPC risk, and even this HLA markers are also important determinants. So you asked me that, could you combine all risk factors together in order to do a better, more precise prediction of the national MPC? And yes, we are doing that. But I would like to tell you that all these genetic markers basically are not as precise or as accurate or as these EBV biomarkers. Okay, and I think there's for the EBV early detection, there's a cost effectiveness study is definitely very important to guide whether Taiwan is going to use or whether Hong Kong or Guangdong is going to use this for MPC detection. I think this is still needs further exploratory studies. Now I'd like to change the gear to the leading cancer deaths in Taiwan. That's the liver cancer. And cancer has been the leading cause of death in Taiwan since 1982. And you can see that the top one is a malignant neoplasm. But you can see that an age-adjusted mortality rate of cancer in Taiwan is going down from 2008 to 2020. But if we look at this different cancer sites, the left-hand side is the instance and the new case number per 100,000. And just now we have discussed about the female breast cancer in Taiwan is increasing. But there's a very unique curve, as you can see here. That's the liver cancer mortality and the instance in red. They are all declining. And I would like to tell you why there's a significant decrease in liver cancer mortality and instance in Taiwan. And we have to use this molecular biomarkers to try to implement it in clinical practice as well as public health policy making. And this is my mentor, dating back to 1974 when I was very, very young. And this is Palmer Beasley from University of Washington. At that time, he was studying hepatitis B in U.S. Naval Medical Research Unit 2, number 2 in Taipei. At that time, he's in Taipei. And he carried out a study of more than 22,000 men in Taiwan and after the long-term follow-up study. And you can see that hepatitis B surface antigen positive person have liver cancer mortality per 100,000 around 1158, and HBsAg negative one is only 5. In other words, there's a 200-fold difference in liver cancer mortality. If they were surface antigen positive, they were chronic hepatitis B patient. And Palmer is a very good epidemiologist and also a very good medical doctor. And he tried to elaborate why Taiwanese have so high prevalence of hepatitis B surface antigen. And he found that if mother were carrier, then her son or daughter are more likely to become a chronic carrier. And if mother were E antigen positive, it means that hepatitis B is in a very large scale reproduction, and then the children will have 85% to become this chronic carrier. Then Palmer said, well, if that's the case, can we help the children in Taiwan? And he carried out the very first vaccine trial in Taiwan. And you can see here, for the children on the right-hand side, in the control group, and almost after 1 year, 90% of the children recruited in control group, they become a chronic carrier. But for those who receive this hepatitis B immunoglobulin with hepatitis B vaccine, then only 6% of them. So the efficacy of hepatitis B vaccination is more than 95%. It is such successful one. So Taiwan government consider that if that's the case, then we have to initiate the very first national vaccination program in Taiwan. And it is also the first one in the world. And we have to use biomarker to identify whether the mother is a surface antigen positive or negative. And then if they were surface antigen positive, further test another biomarker for E antigen positive. And infant born to E antigen positive mother have to get HBIG, immunoglobulin, and vaccine. If we're HBeIg negative or surface antigen negative, they got the vaccine only. Okay, and after we implemented this the nationwide hepatitis B immunization program of newborn in Taiwan, and you can see that mothers in Taiwan are really cooperate with this program, and the vaccination rate is over 90% before 2001, and up 2001, it's all greater than 95%. And Professor Zhang Meihui published a paper in New England Journal of Medicine in 1997. She found that for those vaccinated boys and girls aged 6 to 9 years old, and for those have liver cancer incidence of only 0.13 per 100,000, but for unvaccinated cohort is 0.52. In other words, 75% of the vaccinated people can prevent their liver cancer. And this documented that, yes, we can use vaccination to help the people. Unfortunately, Taiwan have a lot of people already got the infection, already become the chronic carriers of hepatitis B or hepatitis C. And then we have to help this kind of chronic hepatitis B or hepatitis C patient. How can we help them? And this is a big challenge to Taiwan public health practitioner. And fortunately, we have a long-term follow-up study, the review of HBV study. And as you can see here, this is a paper published by Yang Huaiyi. He is also an important collaborator with Dr. Santella and Dr. Wu Huizhen. And in his paper, you can see that after the 9-year follow-up, E antigen positive person have a much higher liver cancer than those who were E antigen negative. And of course, the non-carrier it has the lowest one. So the relative risk is 1, 10, and 60 for S antigen positive alone and both positive. And after this paper was published, a lot of people say, okay, E antigen is important. But in year 2006, we published a paper in JAMA, and we found that serum HBV DNA level was associated with the HCC risk. And in a dose-response relationship, the higher the HBV DNA level, the higher the HCC risk. And if that's the case, then now we are able to differentiate chronic hepatitis B patient to different groups. Some are at very high risk to develop HCC. Some have lower risk to develop HCC. Then if we want to consider the cost effectiveness of any kind of antiviral program, then we know how to triage the patient into treatment group or non-treat group. And we also test for HBV genotype. And this come up, there's risk predictors for end-stage liver disease progression, for viral factor, E antigen, elevated viral load, HBV genotype is important. But in addition to that, the age and hepatic inflammation, as well as family history, alcohol consumption, gender, male gender are also important. So they are so-called the multiple risk predictors. Then use that, we can develop this an HCC nomogram. For example, if there's a male and age 50 to 54 years and with without family history, without alcohol intake habit, and with an ALT level greater than or equal to 45, and with an E antigen negative and higher viral load, 10 to the 5th, then the total score, as you can sum up the total score, is 12. Then we can tell a patient, so say your 5 years risk is 4 to 5% to develop HCC, and 10 years risk is 10 to 11%. And the patient will say, oh my God, then I need to get some help. And before we have this antiviral, we use abdominal ultrasonography to do the early detection of the liver cancer to prevent their death from this, the liver cancer. But after we have this antiviral available, then we decided which kind of patient should receive this antiviral therapy. So biomarker is very important. As shown here, E antigen positive, negative, or HBV DNA, or ALT, this is a liver function data and examination data. Then age is also important. So you can have a management algorithm of a chronic hepatitis B patient. And we all know that hepatitis B C virus was identified by 3 Nobel laureates. And in this entire world, if you look at this is a liver cancer instance, you found that in East Asia, in Central Africa, have a very high liver cancer instance. And this is coincide with the high prevalence of HBV and HCV infection in the world. So if that's the case, then what can a government do to try to help the people who already become chronic hepatitis patient? And this is our review of HCV study show that viral load, viral genotype, and serum ALT level are all important. And we come up this kind of risk predictor as well. I won't go to the detail. Okay. In year 2003, after the SARS outbreak, we started our chronic hepatitis therapy program, and for both chronic hepatitis B and chronic hepatitis C. And these are the number got treatment. And I would like to mention that after 2019, Taiwan used very expensive antiviral, anti-HCV drugs, that's a so-called direct-acting agent to treat HCV patient. And this is a recent published data. And I would like to share with you that on the panel A, age standardized rate of chronic liver disease and cirrhosis mortality. After year 2003, the green broken line, you can see very drastic decrease in this liver cirrhosis mortality. And on the panel B and panel C, this hepatocellular carcinoma mortality and incidence, they all declined very drastically. And this figure is not easy to interpret this the data for the efficacy of the data. However, in our age period cohort analysis, and you can see that we compare from the period effect. If we compare 1999 to 2003, that's before the antiviral therapy. And this is 2014 to 2018, that's after the implementation. Then cirrhosis mortality decreased 26%, HCC mortality decreased 50%, and HCC incidence decreased 53%. And for the post-vaccinated and group compared with never vaccinated group, you can see there's an 82% reduction in chronic liver disease and cirrhosis mortality, and HCC mortality decreased 63%, and HCC incidence decreased 80%. Okay. And in our collaboration with NCI, and since we collaborate with them, and we have so-called Cancer Moonshot Phase 2, Cancer Moonshot 2, and we have an aim to reduce the 50% cancer mortality by 2050. So according to this kind of analysis, and you can see that after this implementation of the antiviral therapy, and also the implementation of HCV treatment, we use this kind of joint point analysis. And you can see here, I go through this one. We have an aim to reduce cancer mortality by 50% by 2050. And according to our estimation for males in Taiwan, and the 50% reduction in mortality of liver cancer can be reached by 2046. But for the female, we can reach it by 2032. So it gives us the confidence that, yes, indeed, antiviral therapy is very important for Taiwan, and we can reduce liver cancer mortality a lot. Now, I would like to shift another example, and this example is for this stomach cancer. And this slide shows the stomach cancer incidence rate and in Asia, as well as in South America, have higher stomach cancer incidence. And this map coincides with the Helicobacter pylori infection, shown in orange in this Asia, as well as in South America. And in Taiwan, we use this Helicobacter biomarker. There's several different kind of biomarker can be used to detect Helicobacter pylori in the stomach. Anyone who got this kind of infection, then we get them this antibiotic treatment. And as you can see here, after the SARS outbreak, when I was working in this Ministry of Health, we implemented this Helicobacter pylori infection treatment, and the treatment number increased after 2006. And as you can see that stomach cancer mortality declined accordingly. And we have a lot of confidence that for both men and women, by 2039 or 2040, we can reduce the 50% of gastric cancer mortality in Taiwan. That's 10 years ahead of this moonshot goal in 2050. Okay, last part of it, I would like to go through this coronavirus. I became the health minister because no one want to jump into the volcano when there was the outbreak. And our former president and premier said, well, CJ, you are an epidemiologist, you should sacrifice yourself. And I say, okay, I took it. And when we have this SARS outbreak, fortunately, we have a very good containment of the SARS outbreak. But SARS at that time in year 2003 is not easy. At the very beginning, before the April 16 of this 2003, nobody knows SARS was caused by virus. And at that time, there was no definite diagnostic methodology and no RT-PCR because we don't even know that what that virus is it caused. And we have no antiviral, we have no vaccine. Then how are you going to implement a very good public health policy or intervention program? At that time, we consider that the isolation of this infected or close contact are very important. And we use this kind of strategies for this containment of COVID-19 in Wuhan, and I will share with you in a very short time. Okay, for the containment of COVID-19 in Taiwan, that's at the end of 2019, our CDC officer already found that in this website, Wuhan have a cluster of atypical pneumonia. So we immediately send a reporting email to inform WHO and China CDC. On the same day, China CDC reported to WHO there are 27 cases in Wuhan. On the same day, Taiwan already implemented onboard quarantine. In other words, any direct flight passengers from Wuhan has to be quarantined for 14 days. And on January 7, the causal agent of COVID-19 was announced by WHO. Fortunately, we can use that to identify the infected people. We use this kind of infection marker to do it. And Taiwan had the first cases on January 21st, and we have an emergency meeting of National Security Council chaired by President Dr. Chien-Jen, and we activate our Central Epidemic Command Center. Okay, and the Taiwan model is that prudent action, rapid response, early deployment, transparency, and public trust. Okay, all of you already know very well. There are three phases of COVID-19 containment. The first one is so-called non-pharmaceutical intervention, NPI, because we don't have this vaccine, we don't have antivirals, and what can government and people do? And at that time, we aim at zero COVID-19 in Taiwan. When there's a vaccine available, then we get into the phase 2. We have tried our best to increase the immunized people. And the aim is the zero COVID-19 still, plus the rapid increase of vaccination coverage. And when Omicron came, it spread so quickly, and we cannot stop the infection using the vaccination, but we can use rapid test and antiviral to prevent the deaths and severe cases of this unvaccinated or vaccinated people. And we have to live with the virus. These are the three phases we have in Taiwan. So we do have this biomarker. That's the COVID-19 RT-PCR test. But in Taiwan, we don't do city lockdown. We don't do mass screening, but we use ICT, big data, and AI technology. And what we have been doing is that once there's an inbound passenger, we do the test, and positive one has to be quarantined for 14 days. And if this one will domestically infected, and we have to do epidemiological investigation to identify all the close contact of this infected person, they have to be home quarantined. And we do very precise contact tracing and testing. We isolate all this close contact and inbound passenger. And we use this digital fence to try to check whether this kind of quarantined people or isolated people are left out of his residential area. And use this kind of smart tracing system and also the home quarantine and home isolation. I would like to share with you, this is an index, so-called stringency index of COVID-19 containment developed by Oxford University. It's a composite measure based on 9 response indicators, including school closure, workplace closure, travel ban, and so forth. And it's scaled from the 0 to 100. 100 means very, very stringent, and 0 means not stringent at all. And as you can see, under the lowest one, the purple line is Taiwan. Taiwan has very low stringent index, means that we don't close any school, we don't close workplace, we don't have a travel ban. Then Taiwan should be a very dangerous place, right? But fortunately, all these close contacts were home quarantined or home isolated. So in total, we isolated or home quarantined more than 1 million people in Taiwan. And as you can see there, that among the by December 31st, 2021, 17,000 confirmed cases. Half of them were found to be positive, test positive, when they were isolated and quarantined. So they have no way to spread out the virus to infected others. And then through this kind of a very stringent contact tracing and checking procedures, we found that it's useful for us to prevent the local transmission. And as you can see here, I once was invited by UK's Parliament Committee on Health and Social Welfare. He said, well, CJ, among this 1 million people quarantined or isolated, how many of them violated the regulation and escaped from this residential area? I told them, well, it's around 0.2%. And they said, wow, 99% of the people comply with the regulation. So I always say that we have to thank these 1 million people. They sacrificed 14 days freedom to let Taiwan people can go to school normally, go to work normally, and all the industry can operate normally. And this is the reason why Taiwan have very good containment. And as you can see, this is a COVID-19 cumulative case. Taiwan, among all the OECD country, Taiwan was ranked the lowest. And if you look at this cumulative asset days, Taiwan was the lowest, the second lowest, next to New Zealand. So this kind of biomarker use is very useful. And by 2022, January 1st, Nikkei Asia ranked this 120 country for this so-called recovery index. Taiwan was ranked as #1. And more importantly, I would like to share with you that during this period of time, Taiwan enjoyed very good economic growth. And this is important. So whether we should lock down any city and how are we going to do the very good application of this kind of testing, I think it needs a very careful consideration. And for this future outbreak, I consider this is very important for all the countries to have a fast application of innovative science and technology breakthrough. I won't go through the details, but in addition to pharmaceutical interventions, I would like to say that digital technology, artificial intelligence, Internet of Things, machine learning, and big data analysis are very helpful for Taiwan to implement a very good control of COVID-19. But I always say, science is never adequate to implement any kind of public health policy. Any kind of public health policy needs the cooperation of the people. If the people don't want to comply with any kind of regulation for COVID-19 containment, we can do nothing. So in a very vibrant democracy, I think there's all this central command center has to gain the trust of the public. The public trust definitely is very important. If there's a public trust of the government command center, then there's the entire society will calm down. There will not be panic, and they were more likely to follow the government guidelines and rules and make the people less vulnerable to disinformation campaign. So I always consider that science is important. Another thing is important is democracy. And on the democracy side, government has to be open, has to gain the public trust and to promote social cohesion. And this is a kind of virtuous cycle of good governance and good citizenship. So I always consider that transparency, public trust, and solidarity are natural product of vibrant democracy. And we thank Taiwanese people, 23 million unsung heroes, they are doing a very good job. Okay, this is my last slide. That's the case. So Nature editor asked me to write small things about this and how bench work and public services can synergize. And these are the 3 lessons I mentioned that scientific training teaches to seek out all the variables that might affect a system. For the entire public health system, and you need to have a very good scientific training. I have used the evidence-based things, and you have to consider all stakeholders that are involved in implementation of public health policy. For instance, in our central epidemic control system, the entire cabinet, 22 ministries are all involved in this COVID-19 containment. But the second thing is that science is never enough to bring about a thriving society. It takes the trust and robust institution and social cohesion. I think I just mentioned about that. And the third lesson to me is a kind of lesson to me. Infectious and toxic agents such as the aflatoxin or COVID-19 have an impact that lasts for decades. So long-range investment in scientific infrastructure pays off. But if we want to reduce this mortality or reduce any kind of severe economic loss due to the pandemic, then you have to take actions very quickly. And these are the lessons I learned when I took a position from this academic research to public services. And this is the last one. And when we consider that Taiwan is doing quite well, and there's in this while the 25, it said that there are 3 persons that can make things better. And this including President Tsai and myself and Audrey Tang. But I would like to mention one thing. This is very important that we all 3 of us consider. It is not a trio. It is the people in Taiwan. And solidarity is the key for the success of COVID-19 containment in our country. With that, I would like to conclude my talk. Thank you very much.
Just want to say, if we tried to quarantine 1 million people, what do you think the percentage of people who kind of didn't stick with the quarantine? But questions?
Questions first. So for us who might not be quite familiar, who is Audrey Tang?
Audrey Tang is
Stay by the microphone so
Okay.
that people online.
Audrey Tang is our Minister of Digital Minister. Yeah. And he's unusual because he's an transsexual minister and is the very first one in Asia. And at that time, we use this kind of digital device a lot to help us to do this quarantine and efforts. Yeah.
Later, 3 questions. So during the COVID era, that's absolutely here. So our public health official, Tony Fauci, he was actually being hammered
Recently.
all like So one of the aspects is the transparency and public faith in the government. So in the future, the pandemic is not going to go away. They will come. So, from your experience, what is the best ways to prepare moving forward so that things like this will never happen again?
I think that it has been discussed in National Academy of Science in the United States through the video conference and also in Pontifical Academy of Science. We all consider that the most important thing is not that there's a pandemic breakout. The best thing is that you have to put off the fire at its beginning. In other words, once there's any kind of cluster of ministerial infectious diseases, you have to report it to International Health Regulation headquarters, and then WHO will send a delegation experts to this area, try to contain it without it spread out. For instance, let's some of this the infectious diseases in Africa, because the reporting system is much better, and then there's World Health Organization can send a delegate to there. The best way is to put off fire at its very beginning. We all consider that once in Taiwan, it's also true. When we've identified the very first dozen of cases, we do very careful outbreak investigation, epidemiological investigation to identify those close contact, those have a travel history, those have occupational contact, and so forth. And when this the size of the outbreak is small, it's much easier to do this precise quarantine and so forth. So this is a very important thing. And the second thing, I think this you have to share the information at the very beginning. And don't trust Taiwan alone can do it. We definitely have to ask other people help us and let everybody know there's a sign there. There's some fire there. You have to do that. And in the future, World Health Organization will implement a so-called DX infectious diseases and program. They are organizing this kind of committees to do that. But Taiwan is not a member of World Health Organization, so I was not invited. But now that's not important. The most important thing is that we definitely have to have this very good preparedness. And preparedness nowadays, I will consider information transparency is important, and technology. For instance, COVID-19 really give all the pharmaceutical companies a kind of suggestion. We can develop a useful vaccine within 10 months. Usually it will take 5 or 10 years to develop a vaccine, but nowadays we can use it for 10 months. Of course, we have to consider the possible side effect or that's an adverse effect, very small percentage of adverse effect of mRNA vaccine and so forth, but it can be improved. So technology improvement is very important. And another way I would like to emphasize is that we have to let all the people know that infectious disease control is everybody's responsibility. And they have to know a very simple infectious disease ABC. So I wrote a book for our elementary school students, or another book that's on public health for the young kids. Let them know to. It's very easy. I will ask you a question. If the R0, it means that one case can transmit it to 2. If R0 equals 2, when it transmitted 10 times, 10 generation, how many cases will be there? It will be 2 raised to the 10. It's 1,024. But if it is Omicron, and then R0 is 8, then transmitted 10 times, how many cases will be there? There's 8 raised to the 10. The entire world population will be infected. And when young kids look at that. Oh, I know it. If we can put face mask and we can wash our hands and we can isolate from others when I'm infected, then R0 will reduce from 2 to 1 or even 2 to 0. Then it's easy to do. So you have to let the people know, yes, everybody can be hero in the pandemic control. I think this kind of health education is very important. Yeah. Yes.
My question is about like you said, for public trust has been a very important aspect in terms of but as I recall, in 2021, when Omicron broke out, and there has been some concerns and controversies during about the authority concerns of decision and policy making. So, what do you think are the greatest challenges that you were facing at the time, and how do you manage to overcome such hurdles?
Okay. Yeah. Misinformation always a challenge to all the countries. At the very beginning of the vaccine in Taiwan, there's a misinformation said that, wow, our vaccination can kill people. That's in Taiwan. And they urge the government to purchase not the AZ because AZ has an adverse effect. They want us to purchase another kind of vaccine. And the elderly, they from this newspaper, and some experts say that the vaccine kills people. So in Taiwan, the entire vaccination rate for the different age group, for those aged 70 and above, only 80% got vaccination. But in Japan, it's more than 95%. In South Korea and Hong Kong and Singapore, they're all greater than 95%. So nowadays, there's still a lot of COVID-19 deaths in Taiwan due to those elderly, they won't come out to get the vaccine. This kind of misinformation is really annoying and really kill people. And the government has to stand up to tell the truth. But I won't say that the political situation in Taiwan is quite difficult to say. So sometimes you government say something, opposition party will say another thing. But transparency definitely is very, very important. Arnie Graham, he's the one who identified this genetic construct for Moderna mRNA vaccine, and he used this kind of genetic construct to produce Moderna mRNA vaccine in the States, and then Taiwan company used this genetic construct to do protein subunit vaccine. And according to the real world data, the efficacy turns out to be the same. But in Taiwan, this kind of protein subunit vaccine was condemned as a wrong thing by some group of the people. This kind of information, misinformation, and even false information is definitely very important. But the best way is let the people know. Don't try to hide anything. A vibrant democracy needs transparency, needs openness. And only in a democratic country can the people have confidence about this government and then can implement a very good content program.